Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is skin care and diabetes, and today's session is brought to you by your zero calorie electrolyte drink Inazal Zero. Now, before moving forward, I would like to announce the last week quiz winners. Dr. Shantanu Kumar Bhattacharya, Kolkata, Dr. Bharat Paveen Mittakota from Surat, Dr. Shashi Kare from Bhopal, Dr. Ashwini Kumar from Kanpur, Dr. Rakesh Bhargav from Delhi, Dr. Asim Sharma from Rampur, Dr. Ashutosh Das from Tamluk, Dr. Sujit Kalsi from Noida, Dr. Satish Kumar Jain from Bangalore, Dr. Ravi Bhatt from Sirsi, Dr. Sarfaraz Arzu Sheikh from Mumbai, Dr. Pradeep Patra from Chhatrapur. Thank you, doctors, to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome Dr. Sanjay Kalra, Chairperson, Education Working Group, International Society of Endocrinology, and past President, South Asian Federation of Endocrine Society. Over to you, sir.
Welcome to yet another episode of FDC Diabetes Essentials. Today we'll be speaking about something very simple and something that we just cannot ignore at all, and that is skin health, skin care. Now, the skin is said to be the largest endocrine organ in the body. In fact, you can say that it is the largest organ in the body because of the sheer surface area that it has. If the surface area is large, it stands to reason that the chances of disease, ill health will also be large, will be higher. So let's talk today about skin care and diabetes, about some aspects of skin health, skin issues. When we speak of complications of diabetes, usually we limit ourselves to macro and microvascular. But then we've realized that viscerometabolic complications are also important. Diabetes can impact each and every viscera of the body. And one such viscera is the skin. Diabetes is associated with various skin manifestations. Nearly 80% of all people with diabetes will have some skin disease or the other. Cutaneous disease can present as the first sign. So often we have patients who present to the dermatologist with pruritus vulvae or with melanoposthitis. They present to the surgeon with a carbuncle, a furuncle that needs drainage, and the underlying cause is actually diabetes. So, skin disease can be the presenting factor of diabetes, and it can also occur. Skin disease can also occur at any time during the course of diabetes. And when we speak of glycemic guardianship, we should speak not only of glucose control, but also of skin care. That is why today's topic is important. One of the commonest complications of diabetes related to the skin is generalized pruritus, just itching. Some people use the word pruritus, but most often now our colleagues in dermatology prefer the word pruritus, Pruritus. Pruritus can be because of various factors. It can be because of hyperglycemia per se, it can be neurogenic, it can be psychogenic, it can be because of uremia, and it can be because of local skin disease. This neurogenic pruritus is quite similar to diabetic neuropathy. Not the same, but similar because the nerve fibers are different. And it can be considered an equivalent of diabetic neuropathy, painful diabetic neuropathy, or an equivalent of microvascular disease. Remember also that in uremia, pruritus is more common. Skin diseases are also associated with the macrovascular complications or comorbidities. So, insulin resistance directly can cause acanthosis nigricans, skin tags, darkening of skin. And these will be associated with central obesity, hypertension, other aspects of metabolic syndrome, and macrovascular complications. Speaking of macrovascular complications, one comorbidity is dyslipidemia. And you can have necrobiosis lipoidica diabeticorum, which is deposits of cholesterol on the skin. At times, skin disease is because of weakness of the skin barrier, and you can have diabetic bullae, non-infectious, or scleroderma diabeticorum, again non-infectious. This is because of alterations in the collagen content of the or protein content of the skin. And at times you have dermopathy just because of diabetes per se. So this is diabetic dermopathy. The patient won't have any other complaints, but there will be darkening of skin wherever there is an insult or a wound or an ulcer. So post traumatic hyperpigmentation is quite often seen, especially over the shin. Diabetic foot can be also considered a part of skin disease. Foot care is a part of skin care, But we have discussed this in earlier events. In India, however, apart from all these factors, we also have a lot of infection. And skin and soft tissue infections are a major cause of concern, complaints for the patient. So they come in frequently. These can be bacterial, they can be parasitic also. Scabies is quite common, but fungal infections are the most common in diabetes. And you will have many patients who come in with balanoposthitis or pruritus vulvae, or maybe tinea cruris, tinea corporis, and it remains undiagnosed for a long period of time or untreated for a long period of time because diabetes has not been treated properly. If you have a patient with recurrent, refractory, or resistant, refractory fungal infection, do consider a course of insulin. Insulin is an anabolic hormone. Insulin will improve the strength of the body, the immunity of the body to fight these infections. At times, glucose lowering drugs directly can cause cutaneous reactions. Though sulfonylureas are theoretically sulfur drugs, the modern sulfonylureas that are available are rarely implicated with any sulfur allergy. However, SGLT2 inhibitors, which we use frequently, are associated with genital tract infections. So, do not use SGLT2 inhibitor in a person with active genital tract infection. Treat that first. Also, do not use SGLT2 inhibitor in a person with even a single episode of upper urinary tract infection. It is contraindicated. Even a single episode of upper UTI in the past is a contraindication for SGLT2 inhibitor usage. If someone gets, again, recurrent or resistant refractory genital tract infections or UTI, it's best to stop the SGLT2 inhibitor, use other drugs for cardiac protection. DPP4 inhibitors are known to cause skin lesions of various types. So, if you're not able to find out the reason and you think it is a drug induced reaction, a drug induced dermopathy, do stop DPP4 inhibitor and see what happens. Insulin directly will not cause any cutaneous reaction, but the wrong technique of insulin can lead to lots of local site reactions. These are common in practice. Bleeding, bruising, pain, lipohypertrophy, all these are common. Pigmentation, vitiligo at sites of insulin administration. There is something known as insulin tattoo, which is hyperpigmentation. So these local site reactions can be corrected by using modern insulins, changing the needle every day. This is the most important, changing the needle every day and ensuring good rotation of the insulin injection site. Insulin can also lead to edema because of fluid retention. This will be for a short period of time. Reassure the patient, tell them not to worry. In diabetes practice, the common causes of edema will be excessive salt intake and deficient protein intake. So, if you are not able to find the cause of edema, all the other tests are normal. Why don't you try to explain salt sensitivity to your patient? Ask them to stop or reduce salt for a couple of days and see what happens to their edema. They might be taking excessive salt. Also, look for their protein intake. They might be suffering from something that we call subclinical kwashiorkor. So, of course, the fluid retention means it is not subclinical, but this is a soft way of conveying to them that they must take adequate proteins. Various other dermatoses are found in people with diabetes. Now, anyone can have a skin disease, but because diabetes has an autoimmune component, so the chances of having vitiligo are higher. Because diabetes is associated with reduced strength of the skin barrier, the chances of perforation dermatosis are higher. Because diabetes is associated with metabolic dysfunction like dyslipidemia, the chances of eruptive xanthomas and xanthelasma are higher. Diabetes is a chronic disease, so is psoriasis, and there is a very strong linkage between diabetes and psoriasis. Both are known to predispose to each other. And bullous pemphigoid is something that many of us physicians miss at times. In case you're not able to understand what the dermatosis is, do not just assume that every skin disease is a fungal disease. Do refer to a dermatologist, ask them their opinion, and let them treat. How do you treat? The most important is history taking and examination. We need trained eyes. In some people, we may need, apart from the routine glucose testing, we may need a CBC, absolute eosinophil count, and serum IgE to diagnose the risk of allergy. Tests like TSH, LFT, KFT will be needed in some people. Very rarely will you need a skin biopsy or a serum protein electrophoresis. How do you manage skin diseases? First and foremost, good glucose control. Glycemic hygiene is important. And along with glycemic hygiene, we need skin hygiene. So make sure that the skin remains moist. At the same time, it doesn't become too moist. Follow the Goldilocks rule, stay in between. Avoid excessive exposure to dry climate, heat, and ice packs. Avoid frequent washing and bathing, especially with caustic soaps or solutions like Dettol or Savlon, other contact irritants. These reduce the natural strength and barrier of the skin. Exposure to pets at home, that may also cause dryness and skin allergy. Avoid skin synthetic fabrics and use loose fitting soft clothing, preferably natural fabrics like cotton, which are permeable to air. When you use a soap, try to use a mild non alkaline soap. Bathe in normal water, a normal temperature or lukewarm water. Don't spend all your time sitting in the bathtub. And you can use, if you wish, wet or cooling wrappings. Relaxation, aerobics, these help skin health because with aerobics you increase the blood flow to the skin. And try to do aerobics, which incorporates all the four limbs, the trunk, every part of the body, so that the entire body gets blood supply and is able to manage its health. At times you have dryness or pruritus, so you can use emollients like urea containing moisturizers. Topical antipruritics are also available, and you can use simple antihistaminics like hydroxyzine, a very simple drug. At times, if you feel there is a psychogenic pruritus, then antidepressants will help. Wherever required, use antimicrobial and antifungal therapy. Follow a general rule that topical therapy is more effective than systemic therapy. However, for topical therapy, you have to counsel the patient properly how to use the ointment or the gel or the cream properly. So, do counsel the patient properly when topical therapy is being used. Adjuvant therapies may also work. Like, for example, someone with excessive sweating may benefit from aluminium hydroxide, alum. What alum does is it blocks the eccrine glands, which release sweat, and it removes them. It blocks and disposes of the eccrine glands. So there is less sweating because the eccrine glands are blocked. Also, drugs like hydroxyzine, which is antihistaminic, they have an anticholinergic effect. Because of the anticholinergic effect, they reduce sweating. And this also can be used in patients with hyperhidrosis. Now, skin care is a very difficult topic. See, the skin is so large. So, obviously, you can spend an entire lifetime learning about dermatology and still not do everything about it. But let's ask ourselves two questions. Our first question is, an iatrogenic cause of pruritus vulvae is SGLT2 inhibitor usage, use of anti-estrogen drugs, Dettol wash, or all of the above. So A, SGLT2 inhibitor usage, B, anti-estrogen drugs, C, Dettol wash, and D, all of the above. Which one is right? Take these as A, B, C, D. The second question is, the best treatment for melanoposthitis is it A, topical antifungal, B, intravenous antifungal, C, Dettol wash, or D, alum wash? So for melanoposthitis, what is the best? Is it A, topical, B, intravenous antifungal, C, Dettol, and D, alum? So again, take these options as A, B, C, D. With this, we come to the end of today's talk. I apologize that I will not be able to take questions today, but certainly we'll catch up with you next Sunday, and we'll be open to questions on skin health as well as the next topics that we take in. So thank you, everyone. And I'd like to thank, as always, Team FDC for taking care of us and for giving us this platform to share information with each other. So over to Team FDC and Jai Hind from my side.
Thank you, Sanjay sir, for the thought-provoking topic, at giving such a wonderful talk. And I would like to thank all the doctors to take part in it. And as that we have completed one more year with Diabetes Essentials, now we have decided to take some break with Diabetes Essentials to gather our energy and to come up with new topics. So we will be coming back again soon. So till then, Jai Hind. Thank you so much.